I'm Iman Nuwayhid. I'm from the Faculty of Health Sciences at the American University of Beirut. And I'd like to welcome you to the start of the third and last day of the 12th LPHA conference. This afternoon we'll have 4 sessions, and the last session will be the closing session. And I invite you all to stick around and listen to Dr. Rima Afifi and Dr. Richard Horton. This is the session not to be missed, like all the other sessions this afternoon. So I have the pleasure to moderate session number 8. Session number 8 will focus on Palestinian refugees, mainly women, and related to issues of pregnancy. Before I introduce the first speaker, we have actually 2 presentations, 2 speakers. Each will have 12 to 15 minutes, and then at the end we'll have the questions and answers and discussions. Please stay muted during the presentation, but you may share your questions on the chat, and then we'll open it. And during the discussion, I'll explain later. You can raise your hand, and we can engage in answering questions and in listening to comments. So again, another reminder to visit the poster link and make sure that you have at least a look at other presentations and contributions for the conference. So going back to the focus of this session, again, it's 2 presentations, and the focus is on Palestinian refugees. So both of them are actually linked to UNRWA. So UNRWA is heavily involved in both presentations. And the first one will focus on the adverse childhood experiences and how it impacts mental health and other health conditions among pregnant Palestinian refugee women. And it will be focused on Jordan. The second one will look at cesarean section rates among Palestinian refugees, but this one will cover 5 settings of refugees. So let's start. I would like to welcome first Ms. Masako Horino. You're with us, Masako?
Hi, everyone. Yes, I'm here.
Okay, so let me take a couple of minutes just to introduce you quickly. Ms. Horino is a registered dietitian with the Academy of Nutrition and Dietetics in the US. She worked as a clinical dietitian for over a decade, and then worked for the US government, focusing on public health programs related to chronic diseases among vulnerable population, mostly promoting healthy lifestyles. Masako has a Master's of Public Health from UCLA School of Public Health. She's currently pursuing a doctorate degree at Johns Hopkins Bloomberg School of Public Health. She also and concurrently works as a research associate and communication officer at UNRWA Health Department at headquarters. She is engaged in and leading several research and evaluation projects, being in implementation research, evaluation research, and also community-based research. So the floor is yours.
Thank you so much. Should I go ahead and share my screen? Oh, you have it. Okay, let me see. This presentation is about association between adverse childhood experiences and mental and health conditions among Palestinian refugee pregnant women in Jordan. My name is Masako Horino, and I currently work as a research associate and communication officer at UNRWA headquarters in Amman, Jordan. UNRWA stands for the United Nations Relief and Works Agency for Palestinian Refugees in the Near East, and it was established in 1949 by the UN General Assembly to provide humanitarian relief to Palestinian refugees who were displaced by the 1948 Palestine War. In Jordan, UNRWA operates 25 clinics serving 22,000 pregnant women annually, and there are 10 officially recognized and 3 unofficially recognized camps. In 2020, we conducted a cross-sectional survey among Palestinian refugee pregnant women seeking antenatal care at 5 mid to large-sized clinics located inside the camp, namely Erbil, Jerash, Malka, Amanu Camp, and Baka. We aim to provide a snapshot on the range of mental and health conditions, as well as lifestyle habits that are related to non-communicable disease. The study objectives for this abstract were to assess prevalence of childhood adversity among Palestinian refugee pregnant women seeking antenatal care at 5 UNRWA clinics, and to examine the relationships between exposure to adverse childhood experiences and mental health and health outcomes. So adverse childhood experiences refers to forms of traumatic child maltreatment experienced early in life before 18 years old. Such experiences include multiple types of abuse, neglect, violence, household dysfunction, and peer, community, and collective violence. Previous research has shown that ACEs are highly prevalent, and increased exposure to ACEs leads to a greater risk of poor health outcomes as an adult, including obesity, diabetes, and hypertension, which are the leading morbidities among Palestinian refugees. Biological and physiological studies have informed that exposure to traumatic experience in childhood can disrupt early brain development and compromise functioning of the nervous and immune systems. Those who are exposed to early childhood adversity tends to engage in high-risk behaviors such as substance abuse and unhealthy lifestyle in a form of coping mechanism to deal with chronic stress. The ACE International Questionnaire was developed by WHO, which was intended to measure ACEs in all countries. We modified this questionnaire to enhance its cultural acceptability and language appropriateness in the context of Palestine refugee community in Jordan. So we conducted interviews and focus group discussions with chiefs of MCH program, head of protection services, health officers, and physicians and nurses from the clinics, as well as with data collectors who were recruited from the local community. And women, the modified version of ACE questionnaire included a total of 33 questions across 8 domains of childhood adversity experienced during the first 18 years of life. And answer choices included yes, no to some questions, and never, really, a few times, many times to other questions. Women were defined as exposed to a domain of ACEs if answered yes, really, a few times, or many times to any of the questions within the category. To generate the ACE score, we summed 8 domains of childhood adversity, excluding marriage and family domain. So ACE score ranged from 0 unexposed to 7 exposed to all categories. The outcome measures included weight status measured by body mass index before pregnancy. Height and weight were measured by a midwife during clinic visit and recorded in the MCH handout. Self-reported health conditions before pregnancy were assessed by affirmative responses to questions asking if a woman had ever been told by a doctor or health worker that she had type 1 or 2 diabetes, hypertension, depression, or anemia before pregnancy. Likewise, self-reported health conditions during pregnancy included affirmative responses to questions asking if a woman had ever been told by a doctor or health worker she had gestational diabetes, gestational hypertension, perinatal depression, or anemia during pregnancy. Other health outcomes included self-report mental health conditions assessed by questions asking if a woman had ever been told by a doctor or health worker that she had anxiety, eating disorder, or suicidal thoughts. Lastly, every smoker was assessed by a question, have you ever been smoking before? And the current smoker included by a affirmative response to a statement, I currently smoke cigarette or hookah. This is a cross-sectional study, which intends to provide a snapshot of a population in one point of time. And sample size was calculated to be 130 women per clinic with a error margin of 5% with 20% expected attrition rate. The 5 mid to large sized clinics were selected purposefully to collect data, and we used simple random sampling to select the women within the selected clinics. So by the end of the data collection, we interviewed a total of 772 women. As for statistical analysis, we conducted descriptive analysis of variables of interest. Logistic regression models were fitted to compute the prevalence odds ratios to examine the association between ACEs and mental and health outcomes. For adjusted logistic regression model, we controlled for age, education, and location of clinics informed by previous literature. Average age of women were 27.5 years old, and 69% of women were younger than 30 years old. 81% of women had high school education or less, 56% lived inside the camp, and 96% were unemployed. Median gestational age among women at the time of interview was 24 weeks, and 82% were in the second to third trimesters. The prevalence of adverse childhood experiences ranged from 0.3% being beaten up by soldiers, policemen, or some in authority to 64% saw or heard someone being beaten up in real life. The most prevalent ACE category was household dysfunction or domestic violence, and the least prevalent category was evidence of collective violence. This is the distribution of ACE scores among pregnant women. 88% of women were exposed to at least one type of ACEs, 69% exposed to 2 or more types, and 26% being exposed to 4 or more types of ACEs. And to compute prevalence odds ratios, we dichotomized the ACE score to 0 to 3 types versus 4 or more types of ACEs. And this table shows both crude and adjusted prevalence odds ratios. They ranged from 1.58 from obesity to 4.2 for suicidal thoughts. Adjusted odds ratios for obesity, depression, anemia before pregnancy, anxiety, eating disorder, suicidal thoughts, and smoking ever before and during pregnancy were statistically significant. So this analysis is the first to show, at least to our knowledge, that ACEs are extremely common among Palestinian refugee pregnant women in Jordan, and they are associated with a range of mental and health outcomes. Our results are consistent with the previous literature that childhood adversity is associated with prenatal depression, anxiety, substance use, and obesity. It's important to recognize the negative effects of ACEs on health outcomes within the Palestinian communities and discuss the opportunities for early intervention, for example, screening within the primary health clinic settings. However, the pros and cons of such interventions should be carefully weighted and also be discussed among policymakers, public health practitioners, clinicians, and with community members. And non-communicable diseases such as diabetes and hypertension are the major health burden among Palestine refugee population. These diseases are consequences of unhealthy lifestyle habits such as overeating or undernutrition of, for example, micronutrients such as micronutrient deficiencies and anemia, and substance use. It's possible that ACEs play an important role in the burden of non-communicable disease, as women exposed to traumatic childhood experience may engage in unhealthy habits in the form of coping mechanism to relieve from chronic stress and emotional problems. However, further analysis is needed to elucidate the potential causal pathways. There are several limitations to be noted in this analysis. ACEs were obtained by retrospective self-report, and it is subject to legal bias. Although data collection procedures were carefully planned to protect privacy and confidentiality of participants, asking the women to fill out this questionnaire in a private room. However, some women might have underreported exposure to ACEs. Our study also used self-report for outcome measures, except for women's height and weight. So outcome measures could also be underreported if women were unaware or unable to recall their medical history correctly. And since data collection was conducted during the COVID-19 pandemic in 2020, we purposefully selected 5 clinics which were willing to participate in the study, had staff capacity, and clinic infrastructure needed for data collection. So this may have limited generalizability of the study results to outside of the selected clinics. Lastly, this is a cross-sectional analysis of data, so the temporal relationship between ACEs and selected outcomes was unable to be established. However, if you think about it, it is conceivable that the onset of smoking, mental and health conditions may have preceded exposure to ACEs. I would like to acknowledge our co-authors for their contribution, Dr. Niveen, Dr. Yang, our colleagues Shada, Dr. Luai, and Dr. Seta. I would also like to thank WHO Emerald Office for funding this study by special grant for research in priority areas of public health. And I would also like to thank for generous and kind support from UNRWA headquarters, Jordan Field Office, and clinic staff to conduct this study. Thank you so much.
Thank you so much, Ms. Horino, and we'll hold the questions until the end of the second presentation. So again, I have the pleasure to present the second speaker who will speak about cesarean rates among Palestinian refugees. And this is our own Zeina Jamaluddine. So Zeina, welcome. And it's good to see you. So Zeina currently is a student of a PhD student in epidemiology, affiliated both with the London School of Hygiene and Tropical Medicine and also the Nagasaki University. Her research focuses on improving the health of women and children, specifically or particularly within the context of conflicts in the region. And she's interested in validating tools, reflecting insecurities, quantifying health and nutrition inequalities, and evaluating the impact of intervention programs. And her current dissertation is focusing on the effect of conflict on small-sized birth, and then small-sized birth at birth on subsequent child well-being outcomes. So the floor is yours, Zen.
Hello, I'm excited to be presenting to you today a study that we did in close collaboration with
Zeina, your
UNRWA
voice is very distant.
on examining the rising cesarean section rates among Palestinian refugees using electronic medical records. So as you all know here, of course, there is around 5.7 million Palestinian refugees living in 5 settings between Syria, Jordan, Lebanon, West Bank, and Gaza. UNRWA is the UN agency that's mainly been providing them with primary health care, including antenatal care for pregnant women. UNRWA does not directly provide childbirth care or hospitalization, except for one hospital in West Bank. Rather, it uses a partial reimbursement co-payment system accrediting non-UNRWA facilities or hospitals. And they noted in the past 15 years a sharp rise in cesarean section rates among Palestinian refugees, doubling from 15% to 31%. And as we have seen in the literature more and more, that rates above 20% or 9 to 20% have not of C-section have not really been associated with beneficial outcomes for mothers and newborns. In fact, what do we know about C-section? C-section is a surgical procedure that actually can prevent maternal and newborn death when used for medically indicated reason. However, but when it's not indicated, there is no benefit, and the negative consequences for mothers and children become very problematic in the short term for the mom and the newborn, but also in terms of long term, with an increased risk in a dose-dependent matter. So the more the woman has C-section, the more the risks increase. And so there is a need to understand rates of C-section overall, but also to understand classify necessary or medically indicated C-section and unnecessary medically unindicated C-section. And so Professor Robson has actually generated a new classification a while ago in 2001 to classify women admitted to deliveries using obstetric characteristics that are generally collected to classify the women and based on that generate different rates of cesarean section in the different groups. And I will be detailing this further. So this study actually proposes to analyze data from UNRWA electronic medical records in 144 health clinics and health centers across 5 settings and countries to examine and contextualize cesarean section rates of Palestinian refugees from 2017 till 2020. We will compare the cesarean section rates among Palestinian refugees using the modified Robson classification and comparing those to WHO guidelines. And we will compare those rates to the host setting where Palestinian refugees reside. And so in terms of the Robson classification, Robson classification uses variables routinely collected in medical electronic records. However, we had to modify it a bit because 2 variables related to inductions were not included, but also the specific type of fetal malpresentation were not recorded in the record. So we generated, instead of the 10 groups of classification of obstetric population, 7 groups. In the first group, we have the nulliparous women. Those are the women who come for their first delivery. They never had a previous delivery. They have a normal fetal presentation that is cephalic, presenting at term. And in this group, the rates of C-section is expected to be around 16%. Then in the second group, we have the multiparous women without a previous C-section. So they previously had a delivery. However, this was a vaginal delivery. They have more than one, probably, or one or more. And the delivery is happening at term with a normal presentation. In this group, we would expect a quite low rate of C-section of around 6%. And then we have the multiparous women with a previous C-section. Those are women who previously had a C-section in a previous delivery, and the rates in that group are expected to be around 50 to 60%. Then we have the map presentation among the nulliparous and the multiparous, where we would expect very high rates of C-section. The multiple pregnancy, where you have twins and triplets, you'd expect high rates of C-sections, and among the preterm deliveries, we'd expect around 30%. The focus will be more on the first three, as the first three represent non-medically indicated C-section, whereas the last are more medically indicated, and so the focus will be more on the first three. So when we look at the data coming from different settings, we see here in blue the inside circle, the cesarean section rate, and in gray the vaginal delivery rate. And then we showcase the contribution of the different groups on top of the blue circle. And so if we look that the highest rates of cesarean sections are happening among Palestinian refugees in Syria, reaching 64%, then Lebanon reaching 50%, Jordan 28%, West Bank, and the lowest rates are in Gaza, 22%. However, the C-section rates are quite high in all the settings, and they are higher than what is associated with improvement in maternal or neonatal outcomes. And then we can see the contribution of the different groups. So we can see that the nulliparous group contributes around 18% in C-section in Syria. But it would make more sense to have a look at within the group what is the C-section rate. So we then present looking in all 5 settings the cesarean section within the nulliparous groups. Those are the ones who are coming for the first delivery, and we highlight in gray in those bars rates that are above the guidelines of 16%. And as we can see that in all the 5 settings, there is the rise in C-section is coming from the rise in the rate of the first C-section. So there are quite high rates of cesarean section among the first pregnancy. And this is problematic because combined with high fertility setting, we would expect those women to become multiparous women with a previous C-section and contributing later on to the other group. Then when we look at the multiparous without a previous C-section, we expect here the low rates of cesarean sections. However, we see that in all the countries except for Gaza, the rates are higher than the guidelines. And this is problematic because in this group, we don't want to see high rates of cesarean section. Then the third group with multiparous women with a previous C-section. In this group, rates actually are reaching up to 94% and 96% in Syria and in Lebanon. And this is actually quite high. And we can clearly see that once a C-section, always a C-section is actually being done in those countries, and that vaginal birth after C-section are very uncommon. There has been some recommendation to do some educational training with doctors and including midwives more into the facility and hospitalization models to try to limit cesarean section. With Syrian refugees coming in Lebanon, UNHCR has noted very high rates of cesarean section, and we're trying to enforce a second opinion policy where 2 doctors have to approve a cesarean section in order to limit the rise in cesarean section rates, and we see sort of a plateau happening. there is some audit and feedback that can actually play a role also in order to enforce limitation in the rise of C-section that is happening in those countries. Now, it is important to note that when we plot Palestinian refugees cesarean section rates over time, this is happening in the dotted line here. We see that there's a rise. However, this is not happening in a vacuum, because when we look at the national data, that is more of a straight line, non-dotted line, we see the similar trends. And so there is a need to target and talk between nationals and also in host community to limit this increasing trend in cesarean section. Another thing to note is that the rise in cesarean section in Syria is also been documented in a study by Aiesh and Saman, showing that actually a lot of OBGYN have left Syria with remaining lots of surgeons who prefer to do cesarean section, but also with the conflict and the war happening, there was an increased demand for cesarean section, and so the rise that we're seeing is also can be explained with a lot of different factors happening around that situation. So as a summary, cesarean section exceed the recommended guideline within most Robson group. Now what we're seeing is the high rates in the nulliparous women, so the first pregnant delivery, that is very high in all the 5 settings, is driving further increases as they become multiparous women with a previous C-section. So then this turns into very high rates of C-section. This is happening in a setting with very high fertility. So there is very high likelihood that the women are going to go and become multiparous women with a previous C-section. There's a need to focus and work between national and refugee communities as the trends are being very parallel. UNRWA is planning also to modify the electronic medical record system to include the data that is related to induction and the types of malpresentation to be able to generate the third classification of Robson. In terms of recommendation, there is a critical target should be to reduce the first C-section, increase vaginal delivery after C-section, so work on the multiparous group with a previous C-section, and improve the quality of care provided and work on nationals and refugees together. I'd like to thank you all for listening and happy to take in any questions, and thank the UNRWA team for everything. Thank you.
Thank you, Zeina. Actually, thank you to both speakers, Horino and Zeina. And I think now we're ready to entertain questions, but we started the session late, so do we still have 10 minutes to go through the Q&A or less? So while waiting for this, let me put the gallery. Okay. So please, anyone with a question, please put your hands up, and I can invite you. And I'm looking at the chat. So there is a discussion that has been, an exchange that has been taking place, mostly regarding the issue of the early marriage. So I think it was Haytham Idris who questioned, why do we consider marriage before 18 as an adverse event? So and whether this was included. So Horino, can you address this thing? And
sure. So 18 younger than first marriage to be before 18 years old was included based on the WHO's international questionnaire for ACEs, and also according to the Jordanian law, we consider the other early marriage.
Yeah, So there has been an exchange in the chat whether this should be contextualized. Is it cultural? So we had different experiences, but I prefer not to get into this discussion now and check if there are any questions for. By the way, Masako, did you include that as one of the components, or family and marriage was not part of the components or dimensions you included?
Sure. So if needed, I'd be happy to share the questionnaire. But as I mentioned, there are 8 different domains of adverse childhood experience that we assessed. And then when we created the ACE score, we did not include the marriage and the family domain because it was just too messy. And then that's how it was sort of recommended by WHO and other study to sum up the ACE score. So we did not include it for ACE score, but then we still conducted the questionnaire and assessed the prevalence of these components.
Thank you. Rita? On the same point, I expect. We can't hear you, Rita. We can't hear you. Rita? You're on mute.
Yeah. Is
Okay.
this better? Yes.
Yeah, no, we can hear you now.
Yes, thank you very much. I do want to go back, Iman, to the issue of what is called child marriage, mainly because especially now we're in the process of decolonizing knowledge production. This is a terrible thing to say, especially when so many people here at age 15 begin to work, get married, etc. Why use child marriage, for goodness sake? This is value laden. It's not being scientific. And what makes us think that we have to set the child's age till age 15 just because in the United States, for example, they do that? I find this a problem, and I think we need to address it in places like this conference, etc., to demonstrate that, look, we don't have to follow whatever the United States or the Anglo-centric journal production dictates or UNICEF dictates. Here at age 15, people are adult. What makes us think that their children, when they start having, I mean, maybe there might be some effect to for health, yes, but also we have to take a look at what else is the context of the women, to take a balance between what can happen to her under age 18 when she gets pregnant versus what can happen to her when she's not married and extremely poor and being violated, etc. at home. Thank you.
Yeah, I think this needs this session on its own. So I do agree that we have always to contextualize and not take things in wholesome, but there have been many studies that have shown that early marriage is associated with poorer health outcomes for the mother and also for the children. But I think everything is legitimate, and I think we need to examine these in this context. You're more engaged in reproductive health, so do we have evidence that speaks to the fact that girls married at an early age are faring well, and that their children are faring well, and which is different than other regions in the world?
Yeah, no. Sorry, just to reply to Rita's comment, and thank you so much for bringing this up, because it was also a very important indicator for Health Department at UNRWA, where we provide primary care services to Palestinian refugees. But then in terms of the context of Jordan, Palestinian communities in Jordan, they still go with Jordanian law. So we did use the 18 and under as an early marriage. but then I guess if in the future, if we want to expand this type of study in Gaza, West Bank, or other regions among Palestinian communities, we do need to discuss further to be more sensitive to their own context. And again, I also mentioned during the presentation when we developed this or modified the WHO's international questionnaire for assessing adverse childhood experiences, we had multiple discussions about how to conduct these questionnaires that are very, very sensitive to women's experience and also to the community. So it was literally a continuous process to improve these questions.
Okay, so let me go back. I think this is an important issue for discussion. I'm not sure whether we can take all aspects of it today. Now there's a religious sort of analysis for that. There's scientific analysis. There's a cultural analysis, and if we still have time, we will go back to it. So. Going back to you, Zeina, there's a question from Naveen asking about the private sector practices there. How does it compare to the clinics or to the settings that you've dealt with? And again, if you can comment, Zeina, on the fact that these clinics follow what's happening in the country. So can you comment on that too?
Yes. Hi, everyone. I think that's a very interesting discussion about early marriage and also the chat. But for the C-section, I'm happy that Gloria is also there because Gloria heads the hospitalization as records, and basically to talk about the electronic medical record of UNRWA, they did not include which hospital that the C-section was happening in. So it was a bit hard to differentiate between private and public, although we tried a bit with Gloria to link up to some of the data in hospitalization in West Bank to try to understand whether there is differences in West Bank in the hospitals that UNRWA contracts. So that's like a subset of the data. And we did find some major differences in areas. So private, there is definitely the element of public and private. It's just, it was a bit hard to differentiate that in the data set we had. And I do acknowledge what Naveen is saying 100% that in Lebanon, for example, quite a lot of the private hospitals are following this high trend of C-section, but also what we know is that Rafiq Hariri Hospital, which is a public hospital, which is also the one that UNRWA contracts, is also has very high rates of C-sections. And so that, not to point one hospitals, but that also is happening not only in the private setting, but also in the public. But yes, definitely there is a lot of research that showed that private settings had higher rates than public hospitals. If Gloria wants to add anything to that, no? Okay. I hope that was that was clear.
I don't see questions on the chat. Anyone would like to contribute to the discussion? So Zeina, my question to you here is how do you intervene with this? It's clear that it's a health system issue. It's practices of obstetricians. It's very clear that in Syria, many women and obstetricians agreed on a time for the C-section because of the instability, insecurity, roadblocks, and all of that. So, but the intervention is somewhere else. The intervention is at the health system level. So, are you thinking about pursuing that line of discussion?
So, also to add to Gloria, so the whole thing was raised because UNRWA saw very high rates of C-section, and they came to want to understand what is this impacting the financial, but also the system and the women. And the discussion was whether to quantify what is when we look at the very places where C-section rates should not be happening, whether we can, whether UNRWA can basically have some influence in talking with doctors, with nurses, with midwives, and to try to change that in a health system perspective. And the issue, like you said, is whether we can like discuss with hospitals putting an auditing system, whether there would be a second opinion policy, whether UNRWA can have a financial clout into basically saying how much they cover based on different things. So that is like things that we've discussed quite a lot with Gloria and Dr. Seta, and it's very tricky also because you can changing any policy becomes also tricky. But I think starting as an UNRWA agency to try to discuss this with hospitals also can have a big incentive for system change. I don't know, Gloria, do you have any additions?
No, I think all what you said is the right thing, and yeah, we are working on this. I think that the first point was to understand the bulk of the problem, and we tried to do this, and we achieved to do this thanks to Zeina and all her support. This is actually an interesting and tricky situation. I was visiting one hospital in the West Bank last week, and they were very proudly telling me that each of their pregnant lady was followed by a specialist during the delivery. I asked them what is your cesarean section rate? They told me between 48 and 50%, and I said this is the reason, because you instead of asking the midwife to follow this, you ask a specialist who, you know, I mean, it's really a complex topic, but I think the first thing we did was to understand the complexity of this problem, and now we will try to find solutions and raise awareness, because the first thing is also to raise awareness between also our own staff, to explain them what's the situation, and ask them to help the ladies and their colleagues to understand this.
Thank you. Frankly, it's so complicated to look at the chat and this participants. So Naveen, do you still, is your hand still up? So you would like to say something?
Hi, it's just a comment because thank you, Zeina, and it's the first time to see the data looking at cesarean section among refugees, so it's very nice to see it. But my question was specifically to the main component for increasing CS, which is previous CS. And this is where the major role of private sector arises, mainly, especially in our culture. I don't know in other regions in Lebanon and Jordan, but here it seems that the people want to have their first child in a private hospital. This is where they advocate for cesarean section. And then the second one will go to another hospital. Now with the different guidelines that we have, it says that you can try for vaginal delivery after first C-section, but this is another challenge. So it's not only about the statistics, but also about the practices of people and health providers at both levels. So this is what I want to just highlight. Thank you.
Yeah. Any other questions? If I may again ask you, Masako, about the plans for prevention and intervention in the case of these adverse childhood events. They've already in the past, and so how do you intervene for the future and with those specific women that have experienced that?
No, it's a great question, and that's exactly the purpose why this study was conducted. And from the beginning, this study was very controversial because we are kind of like, you know, asking very sensitive questions, especially in the context of Palestinian communities. So it's not surprising there are a lot of discussion going on the back chart, and it's to me it's very interesting. I think that a lot of many studies of ACEs in the past has been done mostly in the developed countries, and many low and middle income countries, they lack the basic data on what's going on in terms of this adversity, experience childhood. And especially among the vulnerable populations, it's really difficult for them to raise their voice and then be heard. You know, I really appreciate the opportunity to being able to reach these pregnant women living in the camps, mostly in the camps in Jordan, to at least know their experience and come up with the numbers, because the numbers it shows numbers can be strong indicators, especially for policymakers, because it shows visibly. And I also hear from from the field data collectors who are around the same age as those pregnant women. And according to the observations, basically the lives of pregnant women living in the camps are still very, very difficult. And we're talking about Jordan, so those women are not the direct population who are directly exposed to the displacement from Palestine. They're mostly their parents or grandparents were the first generation of Palestinian refugees, but still their life continues to be pretty difficult. And so for us, especially the policymakers and public health practitioners, to recognize that the GIS experience could contribute to the health conditions and then future a burden of non-communicable diseases, it's very important. I think this is number one. And have further discussion whether it's controversial or, it's more better to be agreed that these conditions can contribute to the population level indicators, but at least have discussions, further thoughts, share our thoughts, and personal experience is always important because they also have a very strong voice. And I think that there are always a lot of priorities when it comes down to providing primary healthcare services, but it could also be one of the policies that can be implemented in the future, or the practice that the healthcare providers always conduct assessment and then further think about what to do for referral to take care of these women who experience some burden that are really difficult to share with others sometimes. So I think for now, this is a start, very beginning of the start. And then also in the future, if we have more opportunities, think about conducting similar studies in West Bank, Gaza, or other host countries of Palestinian refugees.
Okay, thank you, Masako, and for your comprehensive answer. And I think this brings the session to its closure. I think we've covered several points and decide very interesting, complicated discussion. I think we need to address these things very openly. They're very sensitive, but yet we need to discuss these things. So now I would like to hand it over to Dr. Rana Khatib for session number 9. And as you expect, we're going to take a few minutes out of the break between the sessions. Okay, over to you, Rana.
Thank you, Iman. Thank you. So I'll start immediately to gain time, maybe. Hello, everybody. I'm Rana Khatib from Birzeit University, Palestine. Welcome to this session on medications and drug interactions. A very important topic to discuss and highlight, which affects all of us in many ways. Rational and appropriate use of medication, along with appropriate counseling, are essential to enhance medical effectiveness. Yet, not being well operationalized. In this session, we have two interesting presentations on drug interactions and antibiotic resistance, presented by researchers and practitioners in the field. Before we start, I would like to remind you to write your comments and questions in the chat box or raise hands after or during the discussion. First, we will start with Amer Koni to present drug, herb, food, drug interaction with 4 anti-cancerous drugs. And in this study has been conducted in Palestine. Amer Koni is a PharmD specialized in clinical oncology in the Department of Hematology and Oncology at An-Najah University Hospital. He is a research and teaching assistant at the same university. Amer is also a member of Pharmacy and Therapeutic Committee, which aims to develop policies and protocols regarding drug therapy and monitor the efficacy and applicability of these elements inside the hospital. So please, Amer, welcome to this session, and you can start. The floor is yours.
Our research in cancer patients related to drug interaction. The title of our paper is A Comprehensive Evaluation of Potentially Significant Drug-Herb and Drug-Food Interactions among cancer patients receiving anti-cancer drugs. I will talk briefly about the objectives of our study, the materials and methodology, and I will focus on result analysis, conclusions, and recommendations. As you are aware, cancer patients use numerous medications, including more than 1 anti-cancer drugs, supportive medications to handle treatment-related adverse effects, or disease-related symptoms, in addition to other prescribed medications to treat chronic conditions, along with herbs, OTC medications, and certain products. Importantly, around 4% of cancer-related deaths are due to severe drug-related problems, including drug interactions. And this makes research in this area is of paramount importance. In Palestine, there are some studies found a high prevalence of drug interactions among hemodialysis patients and cardiovascular disease patients. But in the oncology patient, drug-drug interactions were not described previously in Palestine. In addition, data regarding the interactions of drug with herbs and other products were lacking in the literature. Our goals from this study is to determine the prevalence of drug-drug interaction in Palestinian cancer population, and to identify and address these potential drug interactions, in addition to determine the factors related to drug-drug interactions and figure out the DDI's characteristics and features. We adopted a cross-sectional design to achieve our goals, and the study took place in 2 main oncology centers in Palestine, An-Najah National University Hospital and Al-Watani Hospital, which are the main two referral oncology centers in Palestine. In this analysis, we included 327 cancer patients. We included all cancer patients with all types and stages who aged 18 years or above, who came to the outpatient clinic to take their medications. However, patients who refused or were unable to participate, patients who did not mention all their medications or who had psychological problems, and hospitalized patients were all excluded from our study. Concerning data collection tools, we use two main sources of information, the cancer patients and the medical records, to collect the socio-demographics and other clinical characteristics of each cancer patient. However, we use the Lexicomp interaction tool to assess the potential drug interactions. We choose this tool because it has a high sensitivity and specificity to detect the drug-drug interactions, and also sometimes used as a gold standard to compare between drug interactions. This instrument classifies the drug interactions according to their risk rating from A to X, where A, no interaction, and X, the combination should be avoided. And it also classifies the drug interaction according to the severity, from minor, moderate, severe, and also according to the reliability of the posted information. Let's move on to our results. Around 69% of our sample were female and 61% were above 50 years old. And 75% had solid cancer. The breast and colon cancers are the most predominant types of our sample. In addition, around half of our participants had chronic diseases other than their primary illnesses, the cancer. Related to the medications, herbs, and other products that cancer patients used, we found that around 52% used more than 7 medications, and 39 were prescribed more than 2 anti-cancer drugs. The prevalence of herbal use was around 56%, and in our sample, we reported that 81% and 29% of patients regularly consumed caffeine and Quaker food, respectively. 1,753 was the total number of potential drug interactions in our sample, distributed as 1,510 drug interactions, 24 drug herb interactions, and 219 drug food interactions. We revealed that the prevalence of drug-drug interactions was around 88%. This means that around 88% of cancer patients had at least one drug interactions. 27% of these interactions classified as major interactions, and around 13% of cancer patients had more than 5 drug-drug interactions, and only 3% were considered as X. That means that the combination should be avoided. Let's talk some examples about drug interactions. We can see that promethazine and metoclopramide, one of the serious and common drug-drug interactions that will increase the risk of extrapyramidal side effects. Also, we found that one of the common interaction interactions, doxorubicin and aprepitant, this combination increased the risk of doxorubicin adverse effects. Also, aprepitant and grapefruit is an example of drug-food interactions that this combination should be avoided because grapefruit will increase the concentration of aprepitant in the blood. However, we didn't find many drug-herb interactions, as this tool, the lexicon, is not specific for or to detect drug-herb interactions, and this is one of our limitations in this study. Also, our results came up with an important finding that there are a significant and positive correlation between the number of observed drug-drug interactions and the number of reported symptoms. However, in multiple linear regression analysis, we found that the number of drug-drug interactions decreased significantly with the duration of therapy, but it increased substantially with the number of comorbidities and the number of all drug use. To sum up, the prevalence of potentially drug-drug interactions among the cancer patient was extremely high, and we recommend local institutions to develop a comprehensive protocol to monitor and evaluate drug interactions by supporting the role of a clinical pharmacist, especially in the outpatient clinic. Also, a group consensus should be reached to use a specific interaction screening tool, as there are many interaction screening instruments. In addition, healthcare professionals must improve patients' knowledge of self-medication and improve their knowledge and awareness about drug interactions. Finally, we recommend conducting more studies to examine the relationship between the observed drug-drug interactions and its clinical implications and economic outcomes. This is our research, which is recently published in the BMC Cancer Impact Factor 4.4. And thank you for your listen.
Thank you, Amer. Very interesting presentation. I have lots of questions follow during the discussion, but now we will move to Banan Aiesh presentation on antibiotic resistance and the cost of that, and stewardship program to reduce antibiotic resistance. So Banan Aiesh has a Bachelor PharmD, American Board Certified in Infectious Diseases, Director of the Infection Control Department at An-Najah National University Hospital in Nablus, Palestine. So please, Banan, you can go ahead and start your presentation.
Hello, everybody. It's my pleasure to be a speaker in LPHA conference for this year to talk about our study, which had the title of The Impact of Antibiotic Stewardship Program on Antibiotics Consumption, the Cost of Antibiotics, and the Antimicrobial Susceptibility Pattern, an Experience from a Developing Country. My name is Banan Aiesh, an infectious disease PharmD at An-Najah National University Hospital in Palestine. As we know, antimicrobials misuse is a worldwide issue, and antimicrobial resistance is considered the most challenging aspect in healthcare settings. It has been reported that as much as 30% to 50% of antimicrobials prescribed in hospitals are deemed unnecessary or inappropriate. So, antibiotic stewardship programs, ASPs, include policies and practices that apply continuous management of rational antibiotics use in the clinical settings. In Palestine, actually, we lack studies investigating the impact of ASPs on antimicrobials, utilization, and the emergence of antimicrobial resistance AMR. Therefore, our study was the first to assess the influence of ASP on antibiotics consumption, cost, and AMR pattern. Regarding the methods, our study was a retrospective quasi-experimental study that was performed to assess the effect of ASP on 3 restricted antimicrobials, which were meropenem, colistin, and tigecycline. So our study assessed the effect of ASP on these antibiotics consumption, costs, and the hospital's antibiogram. The study was conducted at An-Najah National University Hospital, which is a tertiary care hospital in the West Bank of Palestine that provides surgical, medical, oncological, and hemodialysis services for adults and pediatrics. The study was conducted over a period of 20 months before and 16 months after the implementation of the ASP, which was launched on September 2019. Data on antibiotic consumption was reported monthly as days of therapy, DRT, per 1,000 patient days, along with the monthly cost in US dollars per 1,000 patient days. So our ASP was delivered by in-person coaching by an infectious disease clinical pharmacist and an ID specialist. The approaches that we used in our ASP includes front-end or pre-prescription approval of the restricted antimicrobials, which means that these 3 antibiotics need pre-authorization or pre-approval by the ID team before being prescribed to patients. And the other approach was the prospective audit and feedback of the already prescribed regimens. The revision of the antibiotic regimen and these approaches actually were held during the clinical rounds of the ID team, which were done 6 days per week. And also the ID team was available by calling 24 hours, 7 days per week. An important aspect of the ASP was active learning sessions and lectures for physicians, in addition to policies and guidelines of clinical practice implementation. The list of the restricted agents was actually chosen based on available agents in the formulary list of the pharmacy, also based on the cost and the broadness of the spectrum of activity of these agents. Actually, these agents are considered the last options of a treatment of resistant pathogens in our developing country. Unfortunately, the other agents that are approved for MDR pathogen managements were not available in the setting. And these 3 antibiotics were considered our major and last line resources. So the program major purpose was to implement and follow the 4 Ds of optimal antimicrobial therapy: right drug, right dose, de-escalation to pathogen-directed therapy, and right duration of therapy. In the results part, there were a total of 2,367 patients who received 1 or more of the targeted antibiotics that we mentioned, meropenem, colistin, and tigecycline, during their hospital stay. All of these patients were included in the study. They were split into 2 groups, 1,710 patients in the pre-ASP period and 657 patients in the post-ASP group and period. The most significant reduction in days of therapy per 1,000 patient days was seen with tigecycline, with a percentage of change of 62.08% in the post-ASP period. So this table, table 1, shows the days of therapy per 1,000 patient days for the selected antibiotics during the two phases of the study, pre and post intervention. As we mentioned, the maximum reduction was seen with tigecycline, followed by colistin with a percentage of reduction of 59.46%, and for meropenem it was 38.03% of reduction, but it was not statistically significant. Regarding the cost, the mean cost of the three antibiotics decreased by 55.5% in the post-ASP phase compared to the pre-ASP phase. Here in table 2, we also see the change in the cost in pre versus the post-ASP period. And again, the major decrease was seen with tigecycline with a reduction of 62.07% in the cost in the post-ASP period, followed by colistin with a reduction of 59.46% in the post-ASP period, and meropenem, the reduction in the cost, again, it was not statistically significant, but it accounted for 36.68% reduction in the cost of meropenem in the post-ASP period. Regarding the susceptibility pattern of the isolated pathogens, there was a statistically significant increase in susceptibility to meropenem, amikacin, and piperacillin tazobactam with respect to Pseudomonas aeruginosa in the post-ASP period. A statistically significant decrease in carbapenem susceptibility was observed for both Klebsiella pneumonia and E. coli in the post-ASP period. While Klebsiella pneumonia had a significant decrease in susceptibility to amikacin, E. coli exhibited an increased susceptibility to amikacin in the post-ASP period. We can say that the decrease in the susceptibility pattern in the post-ASP period, we mean after the half of 2019, it could be attributed to the COVID-19 era or the post-COVID-19 era, for which the MDR has been reported in an increased pattern compared with the period before the 2019. So yes, as a referral center, as a tertiary care center who served patients from all over the country, and our patients actually are patients who are readmitted many times to the hospital. They are of high risk of MDR pathogen acquisition, and also the CRE has been reported actually much more in the 2020 and the 2019 period compared with the years before. So the increase in the resistance pattern could be attributed to the post-COVID era in somehow. Regarding the mortality, the overall mortality mean was 2.34 plus minus 0.57 in the pre-ASP period, while the mean was 2.88 plus minus 0.95 in the post-ASP period. However, this change in the mortality rate was not statistically significant. And again, the increase in the overall mortality rate after September 2019 could be attributed to the pandemic of coronavirus 19, as the hospital provided services for COVID-19 patients through a dedicated department for COVID patients, along with an ICU also for COVID cases. As a conclusion, this study demonstrated that the ASP had a positive effect in reducing cost and antimicrobial consumption, with no statistically significant effect on the overall mortality rate. However, a long-term evaluation of the ASP's impact is needed to ascertain its enduring influence on antimicrobial susceptibility pattern and infection-related mortality. Therefore, we recommend that all healthcare centers adopt ASP and its relevant intervention based on the most common practices in the healthcare setting, and to closely follow its impacts and adjust interventions accordingly to combat antimicrobial resistance and preserve last-line therapeutic regimens. Many thanks.
Thank you, Banan. Thank you. This is very interesting. Now I will leave the floor for questions and comments. If anybody would like to write something in the chat box or to raise hands for questions. Until I see, I have, oops, just a minute. I have, okay, John, please go ahead, John.
Hello, all my friends in Ramallah, Beirut, and everywhere. I like your study very much, but I'm curious about the timings and the duration. I think a pre and post study is very good, but one suspects that as time passes, the impact of the intervention is going to diminish. So could you please give us a clue as to how long after the ASP intervention was done, you did the follow-up study, and have you attempted to repeat it maybe a year later to see if the influence of education persists?
Thank you, John. This is a question for Banan, I think.
Yeah.
Are you with us? Is Banan with us to respond to this?
It's
They mentioned in the study that they did a follow-up for, they investigated 17 months after the introduction, but this is a question that needs to be addressed, and it is one of my questions, how to enforce implementation and ensure implementation of the ASP. But it seems Banan is not with us. Okay. If she has a problem to join, then we will come back to this question, John.
thank you.
But I'll ask Amer a question. And thank you, Amer, for the study. I'm aware that this is one of the studies addressing drug interaction with cancer, with the patient with cancer. However, I have a question on recall bias, and how did you address recall bias when when you ask patient about certain side effects that they suffer from, and at the same time, how did you capture any any interaction with alcohol? Because people tend to hide that they use or drink or consume alcohol. So how did you address these limitations?
Yes, thank you very much. Yes, we address this problem as one of the main limitations in our study. As you can see, our result find that only 3 or less than 1% of cancer patients consumed alcohol. So this is one of the main limitations, and we cannot ignore or we cannot be assured the exact number of alcohol user in cancer patient to address these drug interactions. As we know, alcohol may play a role in drug-food interactions and may affect the drug clinically with regard its effects or its side effects. However, regarding the recall bias, we asked the cancer patients about all the medications and symptoms they complain. Also, if they did not remember the medications, or we excluded these patients if he do not mention any single medication. Also, sometimes we refer to the caregivers of that patients who take care of cancer patients, and we record all the medications they use.
I see. Yes, this is an issue. Another question I want to, until we get connection with Banan, maybe. I assume that these results were disseminated at the hospital. And I would like to know what was the response of the physicians, you know, especially with the medications, and following up on them. Did they stop using or the avoided medication?
Yes. We started to reduce this type of combination, such as we found a high percentage of use of metoclopramide with the promethazine at the same time, as this interaction will increase the risk of extrapyramidal side effects. So it decreased promptly after these data were published. On the other hand, the role of a clinical pharmacist inside the hospital, where they constantly review the medication charts, especially in the hospital, also reduce this kind of drug interactions.
So you are building a system for monitoring within the hospital, because if you don't have this monitoring system, after you finish your study, things will go back, you know, like before. So what is your next step?
Yes, exactly. As I've mentioned, every single patient who admitted to the hospital, we reviewed as a PharmD all their medications, also during the discharge. However, we plan to expand that in the outpatient clinics, where some of these may be not detected, or the role of clinical pharmacists there are not supported. So we now working to pay more attention on cancer patients who take their medication on the outpatient setting.
Thank you. I have more questions, but if time allows, but we have Banan with us. So maybe,
yes.
Yeah. Did you hear the
I'm
question?
so sorry for the network interruption. Yeah.
It's okay. Did you hear the question? You were with us, or you don't also?
No, actually, I didn't get it.
Would you please repeat it, John?
Right. The question was, sorry, I've frozen here. Interested in the pre and post data, but the issue about giving a group of people an education and intervention to increase knowledge. Practice is often dramatically improved immediately after the educational process, but then tends to fall away the longer time goes on. So the question was, how long post-intervention was the study done? I think Rana told me it was 17 months mean, but was that spread over time? And have you, or are you planning to do another study up to see if that improvement is maintained?
Yes, thank you for your question. Actually, we can say that our study didn't have a washout period. It means that we started our program on September 2019, and the interventions and educations are on continuous basis. So we are daily on rounding and rotations on each patient who is taking antibiotics, and there is a daily discussion with each doctor who is responsible for treating an infected patients. during also the beginning of our post-intervention period, lectures, policies, brochures also were introduced to physicians who are responsible also for prescribing antibiotics. Yes, so the education is continuous, and we can say that till now we are doing our education on daily basis and mainly on-spot education for the prescribers for each case. So let's say that our intervention are continued since the beginning of the study till now. We are controlling the prescription actually in cooperation with the prescribing doctors.
Thank you, Banan. Is this
very much?
Okay?
Thank you.
I hope you can succeed in doing this continuous enforcement. Let me put it this way.
Yes.
We have a
Yes.
question from Ahmed Al-Khatib to Banan. How confident are you that your study is generalizable to other settings, as it could be affected by the sample? I mean, he meant the hospital here.
Yes, exactly. If we are going to adopt this ASP, it will be according to the characteristics of the settings that will do it. For example, we are here at tertiary care center. Mainly more than 60% of the services are introduced to oncology patients, hemato-oncology patients, bone marrow transplant patients. We don't have, for example, gynecology department. Yes, mainly our patients are oncology patients. So actually, as we concluded, we can adopt this ASP according to our healthcare setting. Whether the main problem is prescribing, for example, the preoperative antibiotics, or using the prescription of surgical site infection and prophylaxis, actually it depends on the services that are produced or introduced by the healthcare setting. We can adopt or change the interventions accordingly.
Thank you. Actually, I have a question on your study showed that there was a reduction in the use of these restricted antibiotics.
Yes.
But, you know, in such situations where you address certain antibiotics, if you dig deeper, you will find that there's an increase in other type of antibiotics. Did you investigate this? Because this you shift the susceptibility, the resistant pattern from one type of antibiotic to the other. So how did you, and can you comment on this? How to ensure that you did not increase the utilization of other antibiotics?
Yes. Yeah, thank you. Yeah, actually, as I stated or cleared in the introduction, these three main antibiotics here in, let's say, in my healthcare setting, are considered the major three big guns, let's say. So we were trying to preserve them. Okay, or can you hear me?
Yes, yes, I understand. Yeah.
Yes. Okay. So we were trying to preserve them, and actually our target was to use other preserving regimens. Let's say other beta-lactams, other options that could give us the same benefit and the same outcome. Okay, without compromising the patient of getting the right treatment. On the other hand, we're just trying to preserve carbapenem use to avoid the emergence of carbapenem-resistant Enterobacteriaceae, which is currently disastrous state. That's here. Let's say in West Bank. So we are doing actually other part. Let's say for the administration, we are counting the number of antibiotics that are consumed on a monthly basis, and yes, carbapenems, let's say, are reduced. On the other hand, piperacillin, tazobactam, cephalosporins. Yes, to somehow, their consumption is higher. But for our target or our objective, yes, is to preserve these regimens as much as we can and be rational when prescribing them.
Okay, thank you. Thank you. I wish you all the success in continuing enforcing this
Thank you so
policy. Is there any other comment? Chen? I know the topic is very interesting, but due to time limitation,
Thank you.
I'm told to try to finish, so okay.
Thank you so much for the great
wait,
opportunity.
Yeah, wait a minute, Banan, there's one final question from Bashir, please.
Okay, yeah, okay, sure.
Thank you very much. It's very interesting. Just one point. What do you do with patients who take antibiotics directly from private pharmacies? I know that some patients, sometimes through their relatives or themselves, would actually obtain an over-the-counter antibiotics, which is not unusual.
Yeah.
That's completely another story, which requires lots of...
Yeah,
we can discuss this.
Yes, outpatient clinics are major source, and community pharmacy also have a huge demand on antibiotic prescription. We actually only targeted our acute care setting and the inpatient prescriptions here.
Is there room maybe for providing the patients with instructions not to take antibiotics without the knowledge of their clinicians?
Yeah, actually we do this, for example, in the awareness days and awareness weeks, as we have in the last days. Yeah, the awareness to avoid unnecessary antibiotic use, to avoid the OTC antibiotic use also is given actually to our patients in general in the outpatient clinics and for also the inpatients, yeah, in awareness days and awareness weeks.
Thank you very much. Thank you.
Thank you. Thank you.
Thank you. Thank you all. Thank you. And I will keep in touch with both of you for some more questions
Sure.
to address the research.
You're welcome.
But now we will have a break of maybe instead of 15 minutes, maybe we'll go for 10 minutes. I don't know, Shiraz will say, but to start the session on mental health and well-being with Hanan Abdul-Rahim moderating this session. Thank you, everybody. Bye.
So I think to respect the time, I'm going to go ahead and start. And hopefully, if people are not back, they will trickle back in. So welcome to the penultimate session of this conference. This is the session on mental health. My name is Hanan Abdul-Rahim. I'm the Dean of the College of Health Sciences at Qatar University, and I previously was a member of ICPH. So I'm delighted to be a part of this conference once again. So I'm going to introduce our first speaker, but before I do, I'll remind people to please post their questions in the chat. We'll be taking the questions and starting the discussion after both talks are done. So if you have any thoughts or questions, please go ahead and get them started in the chat, but then we'll also be able to call on people after the two sessions are done. So our first presentation is by Hanna Kienzler. Hanna is a professor of anthropology and global health in the Department of Global Health and Social Medicine and the co-director of the ESRC Center for Society and Mental Health at King's College London. As an anthropologist, she investigates how systemic violence, ethnic conflict, and complex emergencies intersect with health and mental health outcomes in the occupied Palestinian territory, Kosovo, and among refugees in the UK. Hanna conducts research on the mental health impacts of war and trauma on survivors, on what it means for persons with severe mental illness to live and participate in their respective communities, and on humanitarian and mental health interventions in fragile states. So very, very topical for our region. She is also the co-founder of the Refugee Mental Health in Place Network. Methodologically, her work combines ethnography with a range of other qualitative methods, participatory action approaches, and arts-based techniques. So Hanna is with us, so she'll be able to take your questions once we start. And the title of her talk is Values and Practices of Social Inclusion in Mental Health, Learning from Lived Experience in Palestine. So we can go ahead and start the recording, please.
Thank you for giving us the opportunity to present our ethnographic research on the values and practices of community inclusion in mental health, with a focus on the lived experience in Palestine. We're a team of interdisciplinary researchers and research assistants. Suzanne Mitwalli and Yoka Rabaya are public health researchers at the Institute of Community and Public Health at Birzeit University. And my name is Hanna Kienzler. I'm an anthropologist in the Department of Global Health and Social Medicine and co-director of the ESRC Centre for Society and Mental Health at King's College London. Our work would not have been possible without the research assistance provided by Ranim Amra, Noor Hamoudeh, and Dima Masood. So let's begin. Community inclusion features prominently in discourses of mental health and is associated with better mental health and quality of life in relation to belonging, empowerment, and social and civic participation. Conversely, community exclusion has been associated with adverse impacts on mental health. Less is known about what community inclusion means in different sociocultural contexts, and there is almost no research on how people with severe mental illness and their families experience it in contexts of war and conflict. To contribute to filling this gap in knowledge, our ethnographic research explores community as experience and practice by paying close attention to what community inclusion and participation means for persons with severe mental illness in the West Bank of the occupied Palestinian territory. We ask, how is community inclusion experienced and practiced by people with severe mental illness and their families? What support is available to them? And what new versions are articulated that could shape community inclusion for people with mental illness in war-affected settings? Our recent published scoping review indicates that communities affected by war and conflict are largely perceived as fragile as violence and socioeconomic hardship disrupt people's lives and social relations. Communities are often struggle with the breakdown of social services, the disruption of local economies, the exodus of the workforce, high unemployment rates, and poverty. Consequently, it has been found that there is only limited or decreased capacity to support and care for people with special needs, including those with disability and mental illness in community. While community inclusion of people with severe mental illness in context of war is challenging, it is not a luxury, but a human right. The human right to community inclusion in context of peace and war is outlined by the UN Convention on the Rights of Persons with Disabilities, the CRPD. In its Article 19, Living Independently and Being Included in the Community, the Convention states, states parties to the present convention recognize the equal right of all persons with disabilities to live in the community with choices equal to others, and shall take effective and appropriate measures to facilitate full enjoyment by persons with disabilities of this right and their full inclusion and participation in the community. Palestine is a signatory to this CRPD since 2014 and should therefore actively promote disability rights, including for people with severe mental illness. While efforts are underway, they are challenged by the ongoing conflict and Israeli military occupation. Human rights violations are regularly committed against people with severe mental illness, as they are subjected to targeted killings, injuries, and torture by Israeli occupation forces. Violence and intentional de-development of infrastructure and essential services have also been linked to mental health challenges among the Palestinian population overall. Despite this, support for people with mental illness has been limited, including the provision of appropriate and sustainable mental health care. Community psychosocial support services for persons with severe mental illness are almost non-existent. Since there is almost no information available on how people with severe mental illness and their families experience the situation, we explored this matter ethnographically. So our research study took place over a period of 5 years, from 2017 to 2022, in different settings of the West Bank, Ramallah, Jericho, and Qalqilia. Participants included people with severe mental illness and family members, but also service providers and the general public, about whom we're not reporting today. Data collected was varied, We use participant observation, participatory action research, group discussions, and semi-structured interviews, and then analyze these data through triangulation and thematic analysis. Our study findings that we present today include community inclusion and participation, and then a sort of vision around better community life from the perspective of those most affected. The illustrations that you're going to see on the slides are by Amer and from our illustrated storybook, Get to Know Us, Our Lives with Mental Illness in the Palestinian Community. When asked to reflect on what community means, participants reflected on its dual meaning of society and more closely knit communities in Arabic. As such, they considered community in ideal terms as desirable and valued space of collectivism and reciprocity. However, when asked how they experienced community, most had little positive to say, stating that it was unjust, controlling, oppressive, and intolerant. Most participants described being mocked and ridiculed and being called majnoon as soon as moving beyond their home. The Israeli military occupation and related violence further impact on community inclusion negatively. Persons with mental illness described how the military occupation induces insecurity, humiliation, and fear as Israeli forces attack and raid villages and homes, put up checkpoints, and arrest and shoot at people with impunity. To stay safe, people living with mental health conditions and their families restrict their movements and stay home. Several participants had been in Israeli prisons where they had experienced torture and abuse, which they linked to the onset of their mental illness, as well as feelings of insecurity and leaving the home. They avoid certain places and people where they feel unsafe, and this narrows their radius of social interaction even further. Indeed, the family home was the primary communal space where people with mental illness could participate while receiving care and support. However, the extent of involvement in family activities was dependent on several factors, including the perceived severity of the illness, family attitudes, gender, and the nature of the occasion. Some felt that they could easily participate in family events and felt obliged to do so. However, other families failed to invite a relative with a mental health condition out of shame and worry to be stigmatized, or their relative to be ridiculed. A mother reflected, "I feel bad because my daughter is a young woman and I don't want people to say that she's mad. I don't want them to make a big issue out of it, but I feel bad. That's why I don't take her out." Family inclusion was thus partial and in many cases restricted and based on protection rather than empowerment. At the extreme, it excluded people from participating in any meaningful way. Social life outside the home was mainly in the neighborhood. Depending on the illness condition and economic status, men could frequent local cafes, the mosque, and the market, where they could meet friends and socialize, while women's social life tended to be more confined to the neighbors or family members. Most participants complained, though, that their friendship networks had severely shrunk since the onset of their mental illness, as those previously connected with them could not make sense of their health condition or felt ashamed to be seen in public with someone who was widely considered majnoon, crazy. At the same time, some participants described that they found new friends, partly among those with shared lived experience with mental illness. As social networks shrunk, religion played an important role for some. Many felt that conducting prayers and observing Islamic or Christian practices in general gave them comfort. While faith communities or religion were to some extent accepting of those with mental illness, this was mostly not the case in other environments such as the employment sector. Participants felt that paid work was crucial for their mental well-being and social standing. Yet, most complained that they had little to no access to paid work and described various forms of discrimination, including being refused employment if they disclosed their mental health diagnosis, being dismissed from work when they experienced a relapse, and distrust or hostility from co-workers. While almost none of the women we interviewed in Palestine were employed outside the home, they often took responsibility for household chores and taking care of family members, such as children, and aging parents. What then were the visions for a better life in community? Meaningful social inclusion was seen to start with an increase in community awareness and understanding of mental illness. This was perceived to be the first step towards attitudinal change and solidarity, respect, and support for people with mental health conditions as members of society with equal rights. However, people also emphasized that changing attitudes and awareness alone was not sufficient. Rather, this had to translate into meaningful opportunities for community inclusion and participation in areas such as education, work, housing, and social life. Importantly, this should take account of people's different needs and abilities. Some participants expressed a desire for government investment in specialist services, which could support inclusion for people with mental health conditions, such as rehabilitation centers, income-generating interventions, or forms of supported employment. Caregivers also expressed their desire for various forms of support to enable them to continue their caring role. Some expressed the view that the Palestinian Authority should invest in community-based care and daycare centers to provide support and respite. To conclude, community inclusion for people with severe mental illness in war-affected settings like Palestine is ambiguous and dynamic. It requires acceptance and equality, having the opportunity to participate in and contribute to community depending on the person's changing illness-related capabilities, access to quality and affordable support services, and opportunities to work and interact with others in safe spaces free from discrimination and political violence. Achieving this is not straightforward. On the one hand, war and conflict create enormous political, economic, and social challenges for communities, reducing their capacity to support people with severe mental illness. At the same time, there tends to be a lack of political will and stigmatizing attitudes among policymakers, health professionals, and the general public, which make community integration and participation difficult for those living with mental illness. What then is possible in such context? What we propose is a dialogic approach rooted in three premises. First, it is crucial for community support practices and structures to be developed through participatory action approaches. Assessments of needs, development of support mechanisms, and monitoring and evaluation of such support must be participatory, involving various stakeholders, including persons with mental illness and their families, the general public, employers, social workers, health providers, and policymakers. Second, such participatory approaches should be designed with a human rights perspective in order to give particular attention to survivors of violence, people displaced by violence, loss of loved ones, and family and community disintegration. Third, the development and provision of support for community living is an intersectoral endeavor, inspired by the WHO's Health in All Policies approach and building on my call for mental health in all policies in context of war and conflict. We propose that community integration must be developed, supported, and monitored at the intersection between households, communities, services, and national policy making. We believe that it is only by involving the community and persons with lived experience of mental illness from the start that such a rights-based intersectional model can work, even in contexts where there are fewer resources. Thank you very much for your attention, and feel free to get in touch with us or explore our book, Get to Know Us, Our Lives with Mental Illness in the Palestinian Community.
Thank you very much, Hanna, for this presentation. And may I say how wonderful it is to see the work of the talented Amer illustrating the results, truly. Our next presentation is by Jeanine Hourani. Jeanine Hourani is a Palestinian researcher, writer, and organizer. She is an ESRC-funded PhD candidate at the University of Exeter and holds a Bachelor of Biomedicine and a Master of Public Health, both from the University of Melbourne. She has over a decade of experience working across research, policy, and practice in the areas of refugee rights, violence against women, and public health. Today, Jeanine is talking about indigenizing mental health in Palestine using women's resistance as a case study. Is Jeanine with us today? I can't see her in my gallery. Oh, wonderful. Okay, fantastic. So she'll also be here to take your questions when we're done. We can start the recording now.
My name is Jeanine. I'm a first-year PhD student at the University of Exeter. My research topic is on women, resistance, and mental health in Palestine, and I'll be presenting my research proposal to you today. The aim of my project is to investigate how Palestinian women engage in resistance and how they perceive settler colonial violence and acts of resistance to impact their mental health. My aim is underpinned by evidence from Palestine, which shows us that the Zionist settler colonial project deliberately targets the individual and collective Palestinian psyche through tactics such as arrest, imprisonment, interrogation, and humiliation. Evidence also shows us that the negative impacts of settler colonial violence on mental health are greater for women compared to men, but that resistance can be a protective factor for the mental health of women who experience settler colonial violence. At the same time, engaging in resistance can also result in an increased perpetration of settler colonial violence, and this creates a sort of loop between the impacts of settler colonial violence and resistance on Palestinian women's mental health. Despite growing evidence linking resistance, settler colonial violence, and mental health in Palestine, academic discourse and mental health policy and practice remains focused on determining, verifying, and quantifying the effects of violence on mental health and treating trauma biomedically. There is limited work that understands resistance as a central tenet to the attainment of well-being and thus incorporates resistance into mental health policy and practice. This biomedical focus on mental health in Palestine is rooted in the colonial legacy of mental health in Palestine. And this legacy began in the 1920s with the British Mandate, which ushered in an era of coercive mental health practices that were rooted in a focus on the indigenous mind and its supposed deficits. In more recent times, the narrative and practice of mental health in Palestine has emphasized human rights and psychological trauma, which represents Palestinians as agentless and depoliticized victims to be psychologically treated by mental health professionals and legally defended by human rights activists. The human rights and psychological trauma discourse furthers colonial aims by locating the problem within the individual, thus stifling popular revolutionary and liberatory potential. This has been further entrenched through neo-colonial foreign aid agencies, governments, and funding that punishes political behavior by asking psychologists and other mental health grant recipients to report on and differentiate between Palestinians with acceptable, i.e. non-militant, modes of political expression and those with unacceptable forms of political expression. This idea of trauma funding being tied to producing certain types of individuals or subjects not only pathologizes mental health, but also pathologizes resistance. My research thus aims to challenge current Western biomedical notions of mental health and reconceptualize mental health in Palestine in a way that centers resistance and sovereignty as central tenets to the attainment of well-being. My research aims to do this by answering three research questions. First, what are the motivations for and practices of resistance of Palestinian women? Second, what are the social consequences of engaging in resistance of Palestinian women? And third, how do Palestinian women perceive resistance to affect their mental health and well-being? To answer these questions, my research brings together three theoretical frameworks. The first is Indigenous Health Humanities, which is a new field of research emerging from the Australian settler colony. Indigenous Health Humanities understands health to be both social and political, and understands that Indigenous intellect is capable of affecting the necessary social, political, and economic change required for the achievement of better health. The second is an intersectional feminist approach, which considers the complex identities, political context, and intersecting, overlapping, and compounding forms of oppression, and thus represents Palestinians as their full selves, rather than merely as victims of erasure and settler colonial violence. The third is militant intellectualism, which is informed by traditions of the organic intellectual, movement intellectuals, and research militancy. This framework locates the context of learning in the street, as opposed to the academy, by understanding social movements and their actions to be incubators of knowledge. By marrying these three theoretical frameworks, my research centers collective Indigenous intellect while acknowledging the plurality of Palestinian lived experiences. This framework also centers the Palestinian home, street, and organizing spaces as sites of knowledge and theory production. So I start conducting fieldwork next summer, and I'll employ three key methods. First, I'll conduct a participatory workshop, which is an activity-based workshop that I'll be conducting with Palestinian women. The aim of the workshop is to understand how Palestinian women talk about mental health and resistance in their own words. This will be used to create a vocabulary or a vernacular to speak about mental health in Palestine and resistance using definitions that have been constructed by the women themselves, rather than my own personal preconceived notions or definitions set by international organizations or UN agencies like the WHO. After I've completed the participatory workshop, I'll conduct semi-structured interviews and a photo voice project. The semi-structured interviews will be with Palestinian women and with other key informants like mental health workers, social workers, and lawyers. I'll use the language or vocabulary developed in the participatory workshops to develop the interview guide so that we're having a discussion using terms that women themselves use to talk about mental health and resistance. The photo voice project will run in parallel with the semi-structured interviews, and photo voice is a method of inquiry in which participants respond to a prompt using photography. So in this case, the prompt will be, how and why do you resist? And the participants will be required to send me 1 to 2 photos a week for 8 weeks in response to the prompt. And they'll just use their phones to take the photographs. I'll then run a focus group session with participants where they'll share and discuss their photos with each other and how each other's photos make them feel. Again, the focus group guides will be developed based on the vocabulary and language that came out of the participatory workshop. Throughout my research, I'll be based in Palestine, and conducting participant observation, which essentially means I'll be actively involved in women's movements, going to protests, attending organizing meetings, and keeping a field journal. All of these research methods combined aim to try and foreground lived experiences and expertise of research participants by centering the Palestinian street and Indigenous intellect, and this links back to my theoretical framework. And I'd just like to end with this quote from Palestinian intellectual Edward Said, who said, "The exilic intellectual does not respond to the logic of conventional, but to the audacity of daring, and to representing change, to moving on, not standing still." And I think this quote really beautifully speaks this idea of moving beyond Western biomedical frameworks of mental health, and even moving beyond decolonial and anti-colonial thinking towards actually using Indigenous modes of thinking to transform how we think, talk, and understand mental health in Palestine. We need to actively create a mental health system that accounts for Palestinian lived realities. Thank you.
Okay, that's great. Thank you both very much for very interesting talks. We have about 20 minutes of discussion, and I'm going to just make sure that I have my gallery on so I can see who's raising their hands. And if I don't see you, please shout out. I'm going to abuse my privilege as a moderator and start with a couple of questions myself, one to each of the speakers. To start with Hanna. So Hanna, can you talk a little bit about the challenges, the ethical challenges of doing research on persons with mental health issues in fragile settings? So, settings that don't lend themselves to very robust sort of IRB settings, and where their rights can be abused if researchers are not careful. So I'd like to use this platform for you to tell us about how you approached that work to safeguard the rights of your research participants. And I'll give Jeanine her question, and then maybe we can start with the answers. So Jeanine, looking at your 3 research questions, your third question was about the effect of resistance on the mental health of women. And how do you plan to distinguish between the effect of resistance on mental health versus the effect of the conditions that necessitated resistance on their mental health, right? So how to separate those effects. And also maybe your reflections on recruitment. Mental health is, when you say people with mental health conditions or mental health issues, that's a very, very broad spectrum. So Can you say a little bit more about who you're looking to recruit and what issues might make your sample more or less representative? So just think about that while we take Hannah's answer.
Thank you very much, Hanan. And just to say also, Suzanne is with us in the discussion. So because obviously you heard my voice, but the research was really done in collaboration with Suzanne Mitwalli and Yoka Rabaya, who I believe
Absolutely. Is... Hello, Suzanne. And I don't know if Yoka is online. Hello to you. It's very good to see you.
Yes, so we will be answering together. So I can start us off, but Suzanne, just jump in, and Yoka is also in the audience. So thank you for your question. It's a really crucial one, and one that we discussed throughout the project. So this was not just a conversation that we had at the beginning. So ethics here, we did not understand as such as the process of writing an ethics application, submitting it to an ethics board, getting approval, and then getting on with it, but rather ethics to be political, ethics to be social, ethics to be moral, something that was processual throughout the entire project. It was important that we didn't conduct research about people, but really with people. So this is where the participatory element came in. That required, however, a long time of trust building and engaging with one another. So you could see the study took place over 5 years. A lot of time was just spent around building trust, building an understanding of the broad framing that we're trying to investigate, in order to then bring people in to develop the research focal points together with us, to have them decide not only what to research, but how to research it. And that in itself took a long time, of course, to develop, because we were dealing with people with not only severe mental illnesses, but also cognitive disabilities. So it required a lot of creative working, a lot of arts-based methods, a lot of visualization, but also when writing the text at the end, to really co-read, understand together the text. It took us 3 months just to read through the text, right? For which we had created and developed the research over another 3 months of weekly meetings. So it was intensive like this. Also here again, informed consent was a process. It's not a one-off. It's something that we elicited pretty much during every meeting to make sure people were okay being with us, understood why they were there. Stigma is of course real, and the structural violence connected to it is also real, and that's why we don't have the names of our co-authors on the book, but they decided, we offered them to actually put their name, but they decided against it, saying that this was too risky for them and that they preferred sort of an artist name, and they called themselves friends of people with mental illness. So that was really important for them as well. So because co-production, of course, the ideal is that people own the research, that they can sort of disseminate it themselves, but there were limitations, and people felt that quite strikingly. So this is how we sort of tried to work ethically. I'm sure that we arrived at boundaries, that it was not perfect, but it was a process of learning for everyone involved. And maybe Suzanne, you want to jump in as well?
Yeah, I don't have much to add on what you already said, Hannah, but the important element that helped us in this working with a group of people with mental illness was the respect, the mutual respect between us, and also the trust that we built over the period when we worked with them. So it wasn't straightforward. It was like a process that we learned and they learned from us. So it was also mutual learning, and also the thing that helped us also that they were proud of their production, their contribution with the book. So that also was an important element. So the participatory approach was something that really is unique and also helped in the process, and also the thing that we themselves helped a lot from this process, from the participatory approach. Yeah, thank you.
Thank you very much. I think that was a really important statement to make about the sensitivity and the respect of dealing with communities and research in general, and then when dealing with mental health issues. Jeanine, would you like to take that question now?
Yeah, sure. So I think both questions are kind of related. In response to the first one, in terms of how do we distinguish between mental health effects or consequences of the underlying settler colonial impacts versus versus resistance, I think that there have already been, or I know that there have already been so many studies in Palestine that have tried to quantify these things. So there have been studies that have used mental health indicators, that have used indicators around political engagement, that have used indicators around coping mechanisms, and have almost like correlated to what extent resistance and mental health and settler colonialism are related in quite a quantitative way. My research kind of aims to complement that or build on that by providing more of a qualitative analysis. So what I'm looking at is not what mental illness is caused or how mental illness or mental health is improved by resistance versus settler colonialism, but actually how do women themselves in Palestine understand the relationship between mental health and resistance? Do they see them as complementary to each other? Do they not even think about them in relation at all? Is it a subconscious thing? Is it a conscious thing? So it's more of like a qualitative analysis that aims to complement and supplement the quantitative work that has already been done by other colleagues in the field. In terms of recruitment, to speak to that point, the way that I perceive the problem in my research isn't looking at mental illness as the problem necessarily. The underlying problem is settler colonialism. And so how I'm recruiting, how I'll be recruiting participants is actually through women that are engaged in resistance as the first thing, rather than women who identify as mentally ill or have been diagnosed as mentally ill. So I'll be working with key partner organizations in Palestine that work around like women's rights and the women's movement, and trying to engage with that as the starting point, as opposed to mental illness being the starting point. And I'm not only looking at mental illness, I'm looking at in general how mental health and resistance are understood kind of in relationship to each other. There was also a question in the chat, which, if you don't mind, I might also answer, which was about the kinds of resistance I'll focus on, which I think is a really good question, because I think, as I kind of alluded to in my presentation, I'm planning on doing a participatory workshop in which I want to actually understand from the perspectives of research participants how they define resistance and use that as the starting point for my research. So I'll probably have kind of a more sophisticated answer in 6 months' time. But I will say that I think a lot of resistance, or increasingly, we're starting to appreciate the everydayness of Palestinian resistance, the fact that historically resistance has been quite sensationalized and understood as individual acts in response to violence, when in reality practices like Sumud show the everydayness of Palestinian resistance. And I don't want to exclude those kind of everyday aspects of resistance from my work. And on the contrary, I think that there's a growing kind of body of literature that's drawing parallels between how mental health can be a form of resistance. And what I mean by that is Lina Mahadi, for example, talks about political prisoners and how, when they're interrogated, not giving up information is a form of sumud. It's almost like a form of psychic resistance, like in your head, being so strong against the settler colonial project mentally, and that is also a form of resistance. And I think trying to incorporate ideas of like nafs and wa'i and sumud and these words we use in Palestine that aren't translatable to English or into the Western canon are really important for us to center when we talk about mental health in Palestine, and that's not really entered the mainstream literature yet. So
thank you so much for this answer, Jeanine. I might have a comeback, a follow-up, but I want to also give others a chance. I see Bashir Aude has typed in his question. Would you still like to speak, Bashir? You have your hand raised.
Yes, thank you very much. Just two questions, please. Number one, the impact of the occupation on mental health in children. I know that Save the Children have actually published a very interesting study from Gaza earlier this year and indicated that 80% of children there have mental health issues, which is significant. I'm sure that there is some studies about the impact of occupation on mental health of children have been published by psychologists through studies in the West Bank. The other question really is to do with mental health workers. Not necessarily doctors or nurses, but mental health workers in the community who help families, etc. They can be social workers, they can be paramedical workers, etc. Have any colleges of medicine or any institutions courses to provide mental health workers to support families in the West Bank in particular? Thank you very much.
Thank you very much. And I assume this question could work for both of our presenters, or were you targeting Hanna specifically?
Well, whoever can provide me with an answer, I'll be most grateful.
Okay, all right. Who would like to take it?
Shall I give it a start and also to maybe immediately throw a ball to Suzanne, as we have started to work with young people who experience with disabilities, including mental health issues. So maybe Suzanne, you can touch a bit more on the children, the question around young people and children and the ways also here participatory action research is playing out. To talk about mental health workers in the community, that's an interesting question. And what we have found, because as I indicated in the methods section, our research we actually interviewed social workers, we interviewed also nurses and clinicians, etc., psychologists, psychiatrists. And I think what is important to state here is that people are working under extremely difficult, in sort of very difficult contexts in which they have very few resources, where they come often with great enthusiasm, really trying to shake things up, wanting to provide quality mental health care, but facing barriers in their practice to actually provide that care, to provide really meaningful support in the community, visiting those affected, providing medication. Medication is often not available. There's very little time to provide psychosocial support, especially in the government sector. It's different in the NGO sector and in the private sector. And I often felt that it was extremely challenging, and we often admired people working in this field as they worked extremely hard with very few resources in order to do the best that they could under these circumstances. There's very limited financial support available and logistical support available to provide people with severe mental illness with supported living, let's say, in the community. It's very much medication based with some psychological or psychotherapeutic support, but it's very, very limited at the moment. And in the healthcare sector, people know that it is a huge limitation, bemoan the fact, try what they can, but it is extraordinarily difficult at the moment. And this is what also people with mental illness and their family members complained about, that this sort of social support in the community is largely lacking. And we were lucky to work with the Palestinian Counseling Center, who have started to do work like this, to really pilot work like this that could be rolled out if there was sort of financial investment. So this is a group that has really invested into this field and produced sort of prototypes in which community support could be working. But again, community mental health is not cheap and requires a lot of dedication as well. I don't know, Suzanne, would you like to tackle the children's question, because you know much more about this than I do?
We just started our project with, as Hannah said, with the young people with disabilities including also mental disabilities. But we met with them 3 times now for now, and we were trying to follow with the same procedure, creative ways, the way we worked with the other group. The aim of this participatory group is to understand young people's experiences with disabilities in different fields, in education, work, in their social life, and in participatory way. So we learned from our previous experience, and we are trying to repeat the experience with young people with disabilities. And every time we meet with them, we discover new things, and we learn also new things, and how much we need to pay attention to their mental health and to their needs. So it's really we can't talk about all aspects now, but it's really it's challenging work, but at the same time it's interesting, and also we learn much in our process of research. So it's very important to do the research with people with either with disabilities or with mental illness, to include them in the research. And maybe I want to also add that we in our research with that Hannah presented on, we have a directory for all organizations that work with people that provide mental health services. So it might be useful for some who are interested to also to know about the organizations that offer services to children or to also adults with mental health issues.
Thank you so much. Before I draw Jeanine's attention to a comment in the chat about the women to be included, Hannah, you have a question asking you to please repeat the names and roles of the people who made this work possible.
Perfect. So I was just typing, but I could say that also put it into the chat for people to see. So there was Noor Hamoudeh, Dima Masood, and Ranim Amra, and they provided mainly, or started usually off by providing mainly translation help for me. But they also, with time, became more versed in the field and then also helped with data collection along Joke, Suzanne, and myself. They helped with the transcription of the interview recordings, and are to some extent involved in data analysis. So it depends. Some of them have moved on, are doing now their doctoral degrees, their master's degrees, elsewhere have their jobs cut out. Others are still somewhat involved in the project, especially Noor Hamoudeh at the time.
Fantastic, thank you so much. Jeanine, did you take this comment? Did you want to say something about it, or just something for you to consider?
Sorry, did you mean the question about Palestinian women in Lebanon, or was there a different?
Yeah, no, that's the one.
Yeah, I might just quickly also comment on the workers, the mental health workers, just quickly before I get to that.
Sure.
I just wanted to highlight the work of the Global Palestine Mental Health Network, which is a new group that have been set up, and Yourad Hakim, who's from the Palestinian Counseling Center, which Hannah mentioned, is the director of the network. And they're doing a lot of work in terms of capacity building around sharing tactics. So they're a group that mental health workers from the West Bank, from Jerusalem, from Gaza, from diaspora, from the refugee camps can all become members of this network. And there's lots of skill sharing happening across the network. So for example, there's a mental health center in Nazareth that recently ran like a co-sharing Zoom workshop with some mental health workers in Gaza. So there are kind of co-sharing and co-working and knowledge sharing opportunities that are happening throughout within this network. And Laura Sheeha and Stephen Sheeha recently wrote a book or published a book called Psychoanalysis Under Occupation, which talks more about the work that's being done across Palestine and outside of Palestine in terms of how mental health workers are kind of supporting each other and organizing. And something that I think is really important that they mention is how through the Global Palestine Mental Health Network, the mental health workers are actualizing the unification of Palestine, despite the fact that there are systems and structures in place trying to separate mental health workers in these geographical locations from each other. And I think that's really powerful and speaks to the politics of health. In terms of the question about Lebanon, yeah, I think engaging with Lebanese women is really important. My PhD program is only like 3 to 4 years, so I had to narrow it down somewhere, but that is a potential postdoc project that I've been thinking about, so stay tuned.
Okay, thank you. That's fair enough. Thanks so much. Bashir, you have your hand raised. We are out of time. Is it a pressing question? Do you want to write it in the chat? Let me see. Okay, so we do have 2 more questions, but I'm also getting the message that we have to end the session. Can I ask people to sort of exchange their questions and answers in the chat just to respect the time of the next session? I know this has been very interesting and so much more to say, so I apologize to people whose questions I was not able to take, and invite you to continue this conversation bilaterally or on the chat for everyone to see. And I will hand it over to Graham, I believe, to moderate our final session. Thank you so much.
Okay. I think I'm live. It's good for a session to be ending in full flow. Thank you, Hanan, for coordinating that. This is the last session of the conference. There are 2 items in it, but there are some things that need to be said before we go on. Lots of people to thank. Thank you to the presenters, not just the oral presenters, but the poster presenters, some very impressive young researchers on show. They'll all have the opportunity to submit their abstracts to the Lancet, and we'll be in touch about that. Thank you to the tech team at Birzeit, which has made the Zoom conference so seamless and impressive. And one thing that has become very obvious, I think, is that a recording of a Zoom conference is much more concise and coherent than perhaps a recording of a full-face conference. And we have a good audience today, last couple of days, but there's an audience to come who will be able to watch this conference online subsequently. And what they'll see is impressive. So congratulations to everyone on that. And when we, as a steering group, address the issue of trying to find additional resources for the LPHA, it's a tremendous advantage to have this recording of the conference to show people what they can help us to continue in years to come. Thank you also to the reviewers who have looked at the abstracts and ranked them. Thank you to the chairs of the sessions who coped brilliantly with quite a complicated challenge of masterminding a discussion via Zoom and chat. I think almost all of the chairs were Palestinian, and as an international contributor to the LPHA, it's great to see the centre of gravity shifting away from the internationals and towards homegrown talent. Thank you to Rita Jackaman and Huda Zarek on the coordinating committee, particularly to Rita, who always seems to find the means to resource the LPHA conferences, which sometimes as an outsider looks a bit like the Indian rope trick. You know, it exists without any visible means of support. But Rita does manage to find the resources for the LPHA. And we should also thank Birzeit University, which has behind the scenes been very supportive and allow the conference to continue. So for all that, I think we need to show our appreciation and congratulations to all concerned. And with that, we can move on. I'm delighted now. I hope Rima is online with me, but I'm going to introduce Rima Afifi from the University of Iowa, originally from AUB in Beirut. She's the current coordinator of the University of Iowa's Immigrant and Refugee Health and Wellbeing Research Group. And she has very kindly agreed to review the poster presentations for us. So Rima, are you there?
I am here, yes.
Excellent. Over to you.
Thank you so much, Graham. And good morning, good afternoon, and good evening to everybody. It's been such a pleasure to be with you over the last 3 days, and always so inspiring to be part of LPHA's conferences. It always gives me energy to go another year. So I appreciate that so much. I'm honored to have been asked to summarize the posters, and I will do that shortly. I feel like it's a big task and a big responsibility, and I do appreciate the opportunity to do that. And so good to see friends here. All right, 1 second here, I'm opening my slides. All right, can everybody see that?
Yeah.
Okay, wonderful, thank you. So as Graham said, I'm currently at the University of Iowa College of Public Health in Iowa City, Iowa, but my heart remains in the Arab world, and particularly at AUB and the Faculty of Health Sciences, where I spent, I was born and raised in Beirut. I'm originally from Akka, born and raised in Beirut, spent most of my academic life there. And I am a professor at the College of Public Health at the University of Iowa since 2017, and the Faculty of Health Sciences has been just wonderful in allowing me to continue to be an adjunct professor at the Faculty of Health Sciences at the American University of Beirut, which is something that gives me great pride and keeps me connected to the region in ways that are really important for my sense of belonging. All right, so I'm supposed to summarize the posters, and my one sentence is wow. I mean, that's a, my one word. That's a word for the whole conference, but also for the poster sessions. It was just so amazing to read all the posters and all the amazing science that's happening in this space, and such exciting both topics and and work that's been done. So thank you all for all the efforts and for submitting such wonderful work and for doing this work as an active resistance, I think. So just some facts about first authors in this idea of decolonizing knowledge production. I think Graham's already spoken to this in terms of the, who chaired the sessions, but we had 45 posters that were accepted. 40 are online. There were 5 that didn't actually put up their posters, but they were accepted posters. This information is about the 45. 70% of the posters of the first authors are affiliated with institutions in Palestine. 80% are of Palestinian nationality. You'll see the age groups there. We've already spoken about the fact that there's a great majority of young up-and-coming scholars, which is so wonderful, again, as an act of resistance. As I was doing this, I was just reflecting on my father and his generation, and thinking we also should be, the third category is 40 plus, and I think we should continue to unpack that and consider the amazing work that continues to be done by, our scholars and practitioners that are in their, 60s, 70s, and 80s. And so just to also note that that's such an important part of the decolonizing of knowledge and the focus on the amazing work that's been done by Palestinians forever. 42% are females. In terms of location, again, such an important part of decolonizing knowledge production. 42% are In Gaza, 36% are in the West Bank, one's from the Green Line, 9% are in Jordan, Egypt, none from Lebanon this year, which is interesting, and perhaps a statement about the situation in Lebanon. And then we have a few from, outside of the Arab world. In terms of learner status, 44% are current students, which is also amazing. And there's an amazing contribution of researchers and practitioners together. I mean, I think looking at this slide, it's so clear that this is a conference that's very different from any others, that the work that's being done and the centering of local knowledge, the centering of context is so important in LPHA, and such a beautiful way to share space and to share expertise. In terms of topics, there's a whole bunch of topics, and you see them here from sort of specific diseases. And I have the titles of all, but it would take way too long to go over them. And you can see them online. And I would encourage you to look at the posters. They're really amazing. But you see here the range of topics that are, that are covered in the posters. In terms of methods, 58% of the abstracts were specifically related to a survey, so a quantitative method, usually just cross-section, I shouldn't say just, usually cross-sectional. The samples were mostly convenient samples. And in terms of measures, this was really interesting because the measures were either scales that were locally constructed and validated, or using externally constructed and validated scales, so externally validated and then translated to Arabic without validation in Arabic, or externally constructed and validated and then translated into Arabic and validated. So quite a range. It's not, I don't have enough information in all the abstracts to be able to tell you percentages of each of these, but they note these things in the abstracts. Only 4 of the abstracts are related to intervention evaluation, and I'll come to this in sort of the thinking forward. And of those 4, 2 were one group pre-test, post-test, and 2 were intervention comparison group pre and post-tests. And again, there's a lot of debate and critique of the RCT as the gold standard anymore in work that's community health. So I am not at all pushing that, just describing the intervention evaluation. One of the abstracts was a purely qualitative study. And then all the others were specific methodologies related to like conducting an assessment of need, or specific methodologies, that some of them from WHO, that were applied in particular contexts. So the next few minutes, and I only have 10 here, so I'm not going to take more time, but the next few minutes I wanted to give some reflections on what I saw and feed forward. So feed forward to think about continuing to center local voice, to center context, and to continue this idea of decolonizing of knowledge. And feed forward is a term that I learned recently. I was interim chair of our department at the University of Iowa when I first got there, and got the opportunity to have some coaching as a chair. I had been chair and associate dean for a long time at the Faculty of Health Sciences. This was formal coaching. And the first meeting, the person said, "What do you have a hard time doing?" And I said, "I have a really hard time giving feedback, because I'm always thinking about how I give that in a way that continues to uplift rather than make people feel bad." And it's true. It's what I dislike the most about administration. And they provided this idea of feed forward. How can one think about the goals that one wants to achieve, and think about how, what to put in place in terms of strategies in the forward movement? And I like that. There's a lot of readings around that as well. So I'm starting to use that. So with that in mind, these are some of my reflections. Sorry, I don't know why it's not moving. Here we go. So the first is the intentional engagement with the settler colonial context. And so although almost all the abstracts mention the settler colonial context, mention the conditions in Palestine, the Israeli aggression, very, very few, I think only 2, actually embed within the research some measure of that settler colonial context. And so I think going forward, how can we keep that front and center and embed in almost anything we do some aspect that uplifts in our analysis the intentional ability to analyze that? And to LPHA, I wonder if one can consider a repository of scales that measure context. So even if I'm doing something that's different than that, some clinical study or public health study where I know about the settler context, I can quickly go to this this repository and pick a scale or two that I can embed into a larger survey that I'm doing, but that gives me the opportunity to be able to include that as part of the analysis. The second is to continue to promote the use of contextually, locally developed scales in this real need to decolonize knowledge. And again, to LPHA, I wonder if we could consider a repository of locally developed scales. I don't mean this to be, I know that there's very few resources, and so I'm not meaning to add this in terms of resources, but even if it's an uploading of things that come through in the abstracts, like somebody says, I used the locally developed scales, just get that and pull it up. I don't mean a full literature review. And many of these scales have been developed by key leaders in the LPHA context. I would encourage people to think about moving from applied cross-sectional research to intervention. I also want to acknowledge that I understand the challenges of context. I understand that any research at this point is a form of resistance. I understand that very well. And so there is no critique here, just some ideas to think about as we move forward. So is it possible to take some of the research that we've done that has indicated particular gaps that we want to fill or particular areas to advance and think about moving those to interventions? And almost all the abstracts in the bottom in the discussion say we need to think about raising awareness, or we need to think about changing context or changing behavior, or so those are all embedded in the discussion, and I hope that people can uplift those into thinking about interventions slowly but surely. I think that would be a really important thing to do as we move forward. The other thing that I noticed was that a lot of what we're looking at is focused on risk factors, and risk factors are really, really important, but I think there is a need to shift the paradigm from deficits to strengths. About probably 2 decades ago now, when I was just starting my work in adolescent health, I listened to a really great podcast that was, or I think it was a TED Talk that really changed the paradigm for me. They were talking about how we always think about youth at risk. And of course, that's a really important framework to think about. But what if we stepped back and thought about all youth at promise? And how does that completely change the way we engage? So all youth at promise, all communities at promise. And thinking about, if that's the starting point, what do we uplift differently than we would thinking about risks? The concept of sumud has come up throughout the last 3 days. It comes up always in LPHA. There's excellent work around sumud. That is a strength-based. We know that that's a strength-based paradigm shift. So things like sumud. Uplifting the voice of communities. We heard that a lot in just the previous session on mental health. So how do we uplift voices of communities that have been, marginalized, oppressed, stigmatized? And in that, to try to also move us a little bit towards qualitative methods, it will give us a very different perspective than just the quantitative. The combination, the mixed methods approach is beautiful because each of the methods provides a specific entree and understanding of the problem. They come from very different ontologies and epistemologies. They are not comparable, but they are important to do together. And then community engaged research and practice as well, which goes to uplifting the voice of communities. So to LPHA, do we want to consider, if needed, providing capacity strengthening opportunities for community engaged local research and practice? And I know that this is done, but the posters had less of that in it. For researchers to continue to consider community-led research, where actually we as researchers are in service to community. So we are responding to community identified and led need. And that's a paradigm shift for researchers to be in service to community. And to the point that was also recently made in the mental health session, this takes a lot of time. And there's a beautiful quote that I like, which is that we move at the speed of trust, that research and practice in communities moves at the speed of trust. And my final point is to encourage us all to continue evidence-based research and practice. for advocacy and as a resistance strategy. And I hope that these reflections have connected with what you have seen across the last 3 days, and give us some food for thought as we continue to move forward in centering a local context, voice, and decolonizing of knowledge. Thank you. Oh, and I was asked to, after all that, this is probably what everybody was waiting for rather than the last 10 minutes of my talk. So I left the best for last. I was asked to pick the best 2 posters, and this was really hard. And also, I don't like doing this. So, but I did. The process was that every poster was reviewed by 2 reviewers, overall, just judging the posters along, clear criteria that are available if, I think you all have them, but we can easily make them available. And that the reviewers also noted, noted what they considered were the best posters. From those, there were about 10 posters that were uplifted as best posters, and I was asked of those 10 to pick 2. I probably would have picked the 10. All right. So they were, as I've said to begin with, all 45 were amazing. And I do consider that all 45 are an act of resistance. All right. So here we go. Best 2 posters. The first one is, oh, and when I was considering this, I was also thinking about those, all of those criteria of first authors and ensuring that we are thinking about this decolonization of knowledge. So the first is insecurity and associated factors among the Birzeit community during COVID-19 pandemic in the occupied Palestinian territories. The first author is a 20 to 29-year-old male from the West Bank who's a student at ICPH. And I think Baha'u'ddin is online. So congratulations. And I've put here just a brief summary of the methods and results, and I'll just give people a few seconds to look over it. I particularly like this because it focused on a locally developed scale. It uplifted the context, the settler colonial context, which we're talking about, and it was, conducted by a student. The second one is this poster, and this is an assessment of staffing needs at UNRWA health facilities using the WHO workload indicator of staffing needs. And I think Wafat Zaidan is on as well. Wafat is in the 40 or more category. She's female from Jordan and a practitioner. And again, specifically in this idea of the critical importance to combine or to bring together researchers and practitioners together. I think this is really important. UNRWA did an amazing amount of work, and I think uplifted a critical structural factor, which is the continuous removal of resources from UNRWA at a time when resources continue to be, needed across sectors in UNRWA and other places. And so they used the WHO framework, but to really uplift and highlight the critical extra need for resources in a whole variety of professions. Now, thank you. And back over to Graham. Thank you, everyone.
Thank you, Rima. We gave you an impossible task to do that in 10 minutes, but you did it brilliantly. Thank you ever so much. Lots of points there for us to take forward. And now we're a bit behind time, but the final event is Richard Horton giving us his closing remarks, and he can have as long as he wants to do that. Richard doesn't need much introduction. He's the long-term editor of the Lancet. He's half British, he's half Viking. You can see he's I think he's talking from a Viking boat there. He leads from the front. When his editorship is reviewed, hopefully not for a very long time, one of his distinctive characteristics has been forming groups of colleagues to work on tasks, whether it's country reviews or Lancet commissions. But the biggest and longest lasting and most important of those groups has been the LPHA. So Richard, please, your closing remarks.
Well, thank you, Graham, and it's so good to see so many friends here looking well, and also seeing a new generation of researchers come through with this. It's incredible to believe it's the 12th LPHA meeting. I'm going to be quite brief. We're concluding this 3-day meeting, unfortunately, on a day when I woke up this morning to see news reports describing 2 explosions in Jerusalem. And I'm very, very sad about that. Killing at least 1 person, injuring several dozen others. Took place during the morning rush hour. Those explosions followed the killing of a Palestinian teenager overnight. And of course, all this is taking place during what I've seen described as the most acute period of violence in the region since 2015. We're seeing rising violence by settlers against Palestinians. We're seeing increased efforts by the occupier to evict Palestinians from their homes. And of course, I have to mention this because somebody from the media, and I'm from the media, the murder of the Palestinian-American journalist Shireen Abu Akleh. The situation today, and we say this almost every year, but the situation today is serious and urgent. And we mustn't lose our capacity to say that. It's very easy to normalize this situation in our psychologies and to get used to it. And I think one of the purposes of the LPHA is to maintain our levels of shock at the scale of the injustices that we see in Palestinian lives across East Jerusalem, the West Bank, Gaza, and among refugees. I'd like also to sincerely thank all presenters and poster authors for their really excellent work under these very difficult conditions. The standard of the work and the standard of the presentations has been consistently very high. As we've seen in Ukraine, occupation scars and brutalizes societies, all societies. As we learned from the pandemic, biological disease doesn't operate in a vacuum. It's worsened by social gradients across society. It's worsened by inequalities, and the inequalities and disparities reported at this meeting render Palestinians, I don't want to say existentially vulnerable, but close to in many settings. So all the more reason to regret the fact that the World Health Organization's flagship World Health Statistics erases Palestinians, and has done from its very first publication, from the world's attention. This is our global health agency. And in its key annual report that it publishes at every World Health Assembly, it lists all peoples of the world under the heading of nation states and describes their health statistics, except they don't include Palestinians. It's a deliberate elimination of a people. I described it in a piece earlier this year as a statistical genocide, and I maintain that that's what it is. It is a deliberate, a conscious decision by WHO to eliminate a people from its annual tracking of global health statistics. Now, the Eastern Mediterranean Regional Office of WHO recognizes the occupied Palestinian territory as a member country and includes the territory in all of its reports and data, which makes Geneva's exclusion of Palestinians all the more barbarous. Now, I've been assured that WHO will review and hopefully revise its decision to remove Palestinians from its World Health statistics, because that's an essential first step in restoring respect and dignity to the Palestinian people by the world's leading health agency. And this is one of the core reasons for existence of the LPHA, in my mind, to strengthen our international respect for the dignity of the Palestinian people, given the political circumstances that they endure. So we're living at a very serious and urgent time. The situation is getting worse politically, and we've got international agencies that aren't recognizing the Palestinian people. But amid those continued attacks on Palestinian health and identity, I feel inspired by what I've seen this week and what I've read in the abstracts this week and in the posters, because we have seen inspiring examples of resistance. We've seen the agility and the adaptability of the Palestinian health system, despite all of its challenges, in responding to the health emergency that was COVID-19. We've seen the power of community and community engagement to protect and advance health of Palestinians. We've seen the importance of women's agency and resistance, contrary to many Western tropes about women in the Arab world. We've seen the continued significance of UNRWA in supporting the health, well-being and welfare of Palestinian refugees, and long may that continue. And of course, we've seen the contribution of Palestinian health scientists, Palestinian hospitals, and Palestinian universities in guiding improvements in health policy, from maternal and child health to mental health, from tobacco control to oral health, so many issues covered in the presentations and the posters. So despite today's distressing news and the worsening political situation, once again, I do think this conference has demonstrated the central importance of civil society, of the health system, and of, and this is too pompous a word to call it scholarship, but the scholarly community, the research community, the community that is you, a community of people who ask questions and try and answer those questions together. Because what you're doing is, what we're doing, I hope, is providing the fabric of a safety net to protect Palestinian society from further harm from occupation, from siege, and from these acute and longer term shocks that it's experiencing. Now, this is the 12th LPHA meeting, and the quality of the research presented this week, I think, continues to improve. But we need to continue our work. We need to keep awareness of Palestinian existence even alive. And in our small way, I hope that we can continue to do that into 2023. 2023 is our 200th anniversary for The Lancet. I freely acknowledge that we were born as a colonial journal. We were part of a colonial enterprise. In the very first editorial of The Lancet, it actually says, in addition to wanting to be for metropolitan doctors in the United Kingdom, it also talks about colonial practitioners. So we have our own decolonization to do. But we look forward to 2023 to continue this partnership. I hope that we can continue to hold this meeting, an LPHA 13, in some form. At the World Health Assembly, every year for the past many years, actually, we've been privileged to partner with UNRWA to have a symposium at the Assembly on Palestinian health, and I hope that we can repeat that next May. So I just want to conclude by saying thank you for your collegiality, your friendship, for continuing to believe in this partnership. And I hope that we might find a way to meet in real life soon. I miss coming to Birzeit. I miss Ramallah. I miss going to Shifa Hospital. I miss East Jerusalem. I miss visiting you all, and I hope that there might be one last opportunity to visit. So thank you very much indeed for letting me be part of this amazing community that you are. It has been the most important, Graham is right, it has been the most important collaboration, long-term collaboration that I've been a part of during my 30 years at the Lancet, and I'm immensely grateful to it. And so thank you.
Thank you, Richard. I'm not going to give you applause because I don't need applause from us. I've got a couple of final things to say before we close the conference. Just to reflect on what you're saying about advocacy, on Monday afternoon we had a talk from Rohan Talbot, Director of Advocacy at MAP, and he was pointing out two things. One was that advocacy is a long road, and important is to stay on the road. And the other thing he said was everybody's an advocate. And I think everybody in participating in the conference, that advocacy is not what you say, it's what you do. And what people are doing is taking part in an act of affirmation, identity, voice, solidarity, collaboration, all those things, remarkable strength. And the final thing, I think, which I forgot to say first time round in terms of thanks, is thanks to Shiraz Nasser, who's in the background of this conference, masterminding it. She's based at the ICPH in Birzeit, but all year round, Shiraz is a constant, reliable, efficient, friendly presence. And I wouldn't want the conference to end without everyone being aware of that and being very grateful to her for her role, which I hope will continue. But I think with those last remarks, LPHA 12 is at an end. I feel like the man at the Olympics who calls the youth of the world to assemble again, not in 4 years, but in 1 year. And there'll be news about where that's going to be. And the steering group has been given lots of food for thought in the discussions and presentations. So you'll hear from us again. And my understanding is that the conference will be online so that it can be seen either again or for the first time by those who are interested. So I think in the top right-hand corner, there's a leave button. And if we collectively press that, that will be the end of LPHA 12. Goodbye for now.